moving on with the next session, which is a panel discussion on future of artificial intelligence in TB elimination. And I would like to invite the panel members, starting with Dr. Kiran Kumar Rade, Miss Nidhi Bansal, Dr. Shibu Vijayan, Dr. Aparna Chaudhary, and Dr. Ajit Patil. I would like to request Dr. Manu, Mathew to be the moderator for the session.
Quite an interesting topic that many people are interested in. So what I'll do is I have one round of questions for all the panelists, and they will take short 4 minutes, okay, 4 minutes each for a very focused question, very focused answer. I'll give a brief intro. We'll give you a question, and then once the answers are done, we'll hand over to you guys to have your questions. Request to keep your questions also short so that we can stay within time. Okay, great. Shall we start? Okay. So I'll start with Mr. Ajit Patil. He is the MD and founder of DeepTek. Yeah, great. It's up there. DeepTek Innovations. They are primarily a computer visions company. They have bought AI in the computer-based X-ray reading space. AI-based X-ray reading. The AI CAD software. There's a DeepTek Genki. So they are the innovators from that. And my question to you, sir, is from your experience with DeepTek, you have taken something from scratch to mature product. It's a long journey that you have taken forward from there. So as an AI, so if you're talking about diagnostic tests, if you're talking about treatment, there is a already standardized process of scientific evaluation. There's a standard, people are familiar with that process, right? So entering into a greenfield space as an innovator, what are the general challenges and opportunities that everyone can look toward for and learn from you?
Right. No, thanks, Dr. Manu. First of all, really appreciate this opportunity to be here with you all today. It's been a long journey. We have been in the medical imaging AI space for about 8 years. Have more than 450 hospitals, imaging centers across the world using our product. For TB, we have around 175 sites across India. And it hasn't been an easy journey. I think adoption of AI in healthcare isn't an easy process, actually. And we have been lucky to have some good customers. For example, Singapore government adopted our platform at a national level across all the public hospitals in Singapore. Opportunities are significant. I think I would talk about the challenges first. I think developing an AI solution is fairly easy in some sense. I think I would not want to undermine the importance of the effort which goes into it. And we have US FDA clearance. We have clearance across multiple countries. But when you take the solution to the field, what we see that the accuracies will drift from machine to machine, from setting to setting, from cohort to cohort, even from radiographers to radiographers. So when we come to a tuberculosis screening program and you are using an AI solution, how do you know that that product is delivering accuracy on a day-to-day basis? Is there any drift? Is there any bias? And that's one important part. So for that, what we have, what we call is a responsible AI module. And what it does is post-deployment, it does the surveillance of AI accuracy on a day-to-day basis in an automated fashion. And you get risk indicators on a daily basis. Hey, that suddenly there is a drift in AI accuracies because you don't know. It could be multiple reasons. The machine setting has changed. The radiographers have changed. So you need to really be careful about that. And also it indicates if there is a bias for, say, age group. And we have seen a substantial bias across age groups. Or, for example, body weight characteristics. An obese person like me will have different characteristics compared to a thin person from an AI accuracy perspective, actually. So being able to identify that and being able to tune the AI to your given setting through a very easy interface is extremely important from a deployment perspective, actually. And coming back to my Singapore example, we were a young startup 3 years back when we got the Singapore engagement. We were competing with the big names. And the only reason we got adopted is because the customer saw that we understand the challenges of deployment of AI, actually, the responsible AI solution. And luckily, we have done some very large deployments across Singapore. We have seen some substantial outcomes. The TB space specifically, I would like to talk about the other important challenge actually. And the challenge is, it's not just AI. To run a TB program successfully, you need a very comprehensive end-to-end solution. Giving an example, we did a screening program in Romblon, which is a small island in Philippines. You take 3 hours, 4 hours to go to the island. Hardly any electricity, hardly any internet. 2 days, 2,000 people came up for the TB screening program. To be able to handle that kind of a crowd, to be able to register the people, to be able to assess their vulnerabilities, to be able to do right assessment of their TB condition. What we need is a very comprehensive solution. So I think often in these discussions we are having today, a lot of tenders we are participating, it's being undermined in a substantial way, I would say. And we have seen, for example, in just Tamil Nadu state, we have done about 500,000 screening today so far actually on tuberculosis. And having this end-to-end solution, for example, for registration of patients, what we have is bring your own device approach, where any volunteer can use his or her mobile phone to volunteer and participate without the access of internet. And it's not easy to address those issues actually. So having those comprehensive solutions, having a solution where all the scans across multiple sites are aggregated into a single setup, into a single server, pulmonologists and radiologists should be able to easily access those sites through a simple, secure login and look at AI results in an interactive way and finalize reports quickly. So those kind of features are extremely important actually. And of course, analytics, dashboards, having a comprehensive drill down into what is really happening in the sites. What amount of people are getting screened, how many are AI suspects, how many are TB sputum suspects, and the entire spectrum is extremely important. So in short, I think challenges, post-deployment surveillance of AI, extremely important. Extremely important to have a comprehensive and a robust end-to-end system and not just AI actually. So that's, I would pause here. I didn't talk about the opportunities, but I'll come back if required.
Great. So putting chemicals and getting a test result is one thing, but putting chemicals into a highly functioning product is something else. It's the same thing goes with AI data. You can put data and get an ML out of it, but then you have to put that into a product. It has to work on ground. So great point. So next I move on to Dr. Shibu Vijayan, a long-time colleague. He's now at Qure as the CMO over there. Not keeping, I think most of you know Shibu, so I'm skipping over to the question. So right now, X-ray AI CAD is what stands in the forefront. And I think natural progression from there is maybe towards other imaging-based AI. So can we help radiologists to come out with a more sustainable answers, whether it is TB or non-TB? That's the natural progression that we are going ahead with. But if you're looking at TB space alone, where do you think more commercially viable or commercially interesting innovations can come in for innovators to build on?
Yeah, so unfortunately, TB is it's an LMIC problem, and the government and the donors who are in the development sector are the payers. So, I echo what Madhu mentioned. Madhu mentioned about there are smarter ways of adoption in government by paying their money. That is something which is lacking. We need innovation in that space. So we all done the hard work to come up with the innovations, but if there is no buyer, which is a larger buyer is government, and if they are actually kind of not listening to us, then that is the biggest disincentive for anyone sitting in this room. Just want to put that as a disclaimer. But great questions. So I would say subclinical tuberculosis is a big thing which has been discussed, which is a starting plenary session was on subclinical tuberculosis. That's an area where bundling of AI along with maybe radiomarkers and biomarkers. I mean, existing simple biomarkers like an ESR, how it behaves with an AI score, could be a starting point of whether this has potential to kind of break down the disease or not, rather than we thinking about host response, highly expensive biomarkers. That's something very simple. You can start in probably a trial tomorrow. So, which is like these are in any TB patient will get an ESR done left and right, in Indian setting. Second thing, if you look at like a full cascade of TB care starting from the community, where I'm just talking, picturizing Dr. Gagandin Khan's picture about starting from the community, the household community in diagnosis, and then further follow up on. All these are actually data points. And starting from like so we did self-test at home, right? There is a lot more self-care has been pushed. Like, what have we, I mean, how can we learn and leverage from that? And that is a market probably will bring in. And can we think about, again, I mean, as we're thinking about a disease like tuberculosis, you should also think about how are you going to pay and incentivize the patient. Now we are incentivizing the patient when they are getting diagnosed. Are we incentivizing for them to actually go for diagnosis, like maybe a self-test, starting with an AI-assisted reading, right? Probably at a main home is maybe a rapid diagnostic test they can do, and then they can read with an assistance of software. That could be a trigger to go to a health center and get an X-ray done, get a subsequent test done, right? So I mean, I see value in entire patient care cascade, such innovations wrapped with all these LLMs. I mean, the biggest advantage of India is your Nikshay. It's a data hub. If you're not thrashing it down and you're not applying, I mean, the advancements in AI, you are losing that opportunity. I think probably the CTD's thought process is in that line. The initiatives like MIDAS and ICMR's collaboration with other partners are also thinking in that line. That's a wealth of information to actually plan your ACF. You don't need to be doing randomly 100-day campaign everywhere. You probably need targeted 100-day campaigns in certain places, which that information comes up. That is a data over. I mean, I listened to Srinivas' presentation wherein he talks about data insights. You overlay multiple data like social determinants, you look at climate, and a number of other air pollution in Delhi. Like, okay, so where do you need to see? Do you need to do offer Delhiites annual screening or a periodic screening to find out TB? Not only TB, to find out other diseases. So there is a lot more scope in that. But again, I just want to reiterate, when you just engage with the program right up front and make sure that the volume guarantee is there. Procuring, because this is a poor man's disease, and those people who are innovating also need to actually work with the ICMR upfront and ICMR or government, Central TB division upfront to make sure that there is a proper market and adoption and scale-up strategies existing. Thank you.
Great. That really follows on from what Ajit mentioned, that you need to build it into a product. And what you're saying is not just, let's say, X-ray CAD. You can layer on multiple series of data, whether it is care cascade, whether it is ESR, whether lab reports, put it together, and that would probably enhance the usability of even the existing products out there. And you highlighted that, okay, program has a lot of data with it, and there is a lot of wealth in that. And if the program is open to trying to innovate on that, there's a lot of opportunity there. That very clearly comes to the next question to Aparna. Aparna is a program officer with Vadwani AI. So they are the official partner with the Government of India and Central TB Division to build Central TB Division's readiness towards adopting AI. So they are a company. They are not a profit company. They are a social good AI for social good company, and they are working with the Central TB Division to build use cases, build its readiness to adopt AI-based solutions. So they have been engaging in multiple areas. So one of the areas they have built new products which are generally available only with the program. So let's say the example is, you can see those innovations up in the exhibition, the LPA AI reader. So that information is only available with the program. You cannot just generally otherwise pick it. So they are trying to build solutions to the program. So Aparna, my question to you is, now, could you explain that effort? What is the process of engagement with the program where you are trying to make them ready to adopt AI solutions? If there are potential opportunities now that is available, how do innovators take leverage of those opportunities?
To start with, I think as a AI partner for Central TB Division, when we start for any AI solution or any innovation, it goes to understand what is the user need, defining where is the gap where the AI solution or any innovation can come as a supportive tool for the NTP staff. By the end of the day, I think the users are the end users who are the field workers who are going to use the technology. Maybe not the field workers if we are talking about the laboratories at the IRL or CTST level, but any lab level. When we talk about MolBio, it was the end user. We understood what was the end user's requirement, and the government was ready to take that innovation as a part of the program. Same goes for any new innovation which comes, to define the problem, to understand the need base. Second, any technology which comes as a part of the program, if you want it to be adopted by the program, it goes a lot of capacity building for the people who are going to use it. So as a partner, when we talk about, we make not the central team, but the state team AI ready. So saying it AI ready means telling them what is AI solution, how they are developed in a very layman terms. When we are going to any district TB officers or any NTB staff, they do want to understand what data has gone into it, how did you develop it, what was the scoring, how did you come into it. So we have to tell them, we have to spend time with them to make them understand how this is going to help you. And third is to show the impact. So impact not by showing that how much manpower can we provide to you to bring that impact, but in a sustainable way, because manpower can be there, and right now we know that we do not have that kind of manpower for NTP to support from partners in current situation, but the NTP has to take the entire burden. So any innovation should be that sustainable that when they do not have a support system, they can still use that innovation as a part of their program. They do not need anybody to take the ownership to run that innovation in their community. They can work along with that. So the impact in a sustainable way, if it is showing the impact, the government itself want to take those solutions. Finally, I think it's more of developing a standard operating protocol and for the data collection aspect and data sharing policies. I think like ICMR does have mentioned that if the government is ready to share the data, ICMR is ready to share that, and that's what happened for LPA development. We did develop a gold standard database before developing the AI solution. We had microbiologists from across the IRLs who supported in development of the AI solution. So I think all the innovators, if they do understand what is the requirement and how they can support the system without adding an additional burden, which is the concern for everybody. If we do that, I think none of the innovations will be difficult to adopt. It will be time taking. As AI partners, I think it is time taking for us also. But it will eventually see, I think, the acceptance in the people.
Great. So what you're saying is, on one end, there is central TB division's process to adopt an AI solution, but to a large extent, innovators have to be conscious of the perception of the user on ground. Digital transformation is one important thing, but AI is another. Adopting AI is another level altogether. Even now, we are facing trouble. Okay, have you remembered your email password? So that's the state in VR. But at the same time, you take it forward from there, and okay, you're a digitally literate person, and getting people on ground to be happy to adopt that solution, and so that when you move away, there is a lasting footprint going forward from there. So great. So that leads on to the next question I have with Dr. Kiran. Dr. Kiran has been a long-term mentor for us. He's been largely dealing with data. He's the epidemiologist in the entire set. He's now working with Stop TB as a technical consultant. So to you, I have the question is again taking on forward from readiness. So I think Aparna has mentioned some pieces of it, but how should one, as an AI innovator, get their AI innovation ready to use in the TB program context? So what all are the steps that they need to take all the way from the conceptualization level to maturity of the innovation and to final adoption? What is the general timeline or general trend or the general pathway that they should take to reach adoption at scale?
Thank you, Manu, for the question. And I'll actually start with where Aparna mentioned about the traditional approach of identifying the gaps and then trying to find the solution. And that's what exactly one should not do if it is really an innovation. This is the traditional method which could be done otherwise also. And that's where probably the current situation and the scenario and the innovators are stuck. That's what I see. I'm sorry if I'm sounding harsh, but that's the reality. Rather, the innovators should understand that yes, TB is a problem and that's why they're trying to innovate. So try to bring in innovation in terms of thinking that if this is the potential of a particular technology, how it can be applied and where it can be applied, when it can be applied, how it can help the individuals, the program, the patient in a different manner, in a way that is potentially more beneficial as compared to, okay, my adherence was 80% and I need to go to 100%. So how do I fill that gap? There is, frankly speaking, I won't say fun, because there's no fun out here. It's all serious business. But the application should be such that it disrupts the thinking. And second thing, we're actually arguing with my colleague who talked about AI in the morning. What is missing actually in the program right now is access to the information and database. Many will not like to speak on the open forum. I won't hesitate. There is difference between sensitivity of data. Sensitive data is well defined in the government rules, acts, everything. Protection of it is another thing. But there are ways and means of anonymizing, pseudonymizing of the data and still sharing it and making it available to the innovators. And I think India is on a trajectory, larger and outside TV, I would like to say, because this is important. The infrastructure that has been created by Government of India, which was launched just 2 weeks before, is humongous. I think somewhere 18,000 GPUs at a single place, which will be made available. So that shows the intention of the government that yes, and that will be much cheaper as compared to any other services that you take from different global providers. Now, once that infrastructure is available, what the innovators need to do is don't get stuck into those and try to find out. And I think ICMR, actually Shibu mentioned about Midas and other repositories. The time has come. Once upon a time, I was actually evaluating Qure AI's product. It was almost 10 years before, 8 years before. And there was a real struggle. Questions coming from different sources. Have you taken the consent from the individual that you will use this for AI? Fortunately, yes, I had. But otherwise, it was difficult to even give few thousand X-rays for a genuine cause of validation, which was a Make in India startup. That era and time has gone, and probably DG said it or not, I don't remember today, but ICMR has put forth 100,000 high quality labeled data of chest X-rays for tuberculosis for the innovators in public domain. So things are changing, and I don't see that there is no reason why Nikshay will not put such a data, similar data, by anonymizing. There are techniques for pseudonymization and making it available. Otherwise, that infrastructure of 18,000 GPUs will not be of any use. The issue is the innovators need to identify as to how, where the AI component or the tool that they want to develop, how it will fit into, rather than getting stuck into the routine questions and trying to answer just by an incremental IT and technology. And the reason why I'm saying so is that the another thing is simple high level statistical analysis is one thing which answers almost all the questions which we already have. But the information that we have, at least in India, on tuberculosis, both in public and private sector, is so huge that there are patterns which are not known, not recognizable by the human capacity of the brain. We may think that we are superhumans and whatnot. We have 30, 40, 50 years of experience. That's what we hear. But still, there are patterns which normal human brain plus the analytics is unable to identify those patterns, and that should be the starting point, rather than identifying, oh, this is the hotspot and I should do active case finding here. Sorry, if you just use the information which is there in Nikshay, it is numerator, not the denominator. It will only tell you what the program has been able to capture. So you will go in a completely wrong direction if you just go in that traditional trivial way. Sorry for it being long, but that's what is needed, what the innovators need to be disruptive. Of course, you follow the ethics guidelines of ICMR, but but be disruptive. That's what is needed.
Great. Very cleanly from Ajit to Shibu to Aparna, a clean line of thought process is coming, and Kiran has come and disrupted it completely. So that's a great answer. So a number of very elemental points in what Dr. Kiran has mentioned. Although he has not answered the question, but he has given us lots of food for thought. And important thing is what Dr. Kiran has mentioned. If whenever CTD is anonymized, giving out data out for you, that actually tallies into what Shibu was also saying. The TB program collects a huge amount of data. The quantity is simply enormous. If you go and look at the dashboard, even if you tweak something, it takes around half a minute for it to just process and give you a number. So just count itself, the quantity is so huge. So when CTD makes available that data, that will be the opportunity for you to plug in X-ray, your own thought processes, other layers of GIS data, and that would be the opportunity for you guys as innovators.
Don't wait.
Don't wait. Great. Taking forward from there, my next question is to Nidhi. Nidhi is Union's India country director. She brings a lot of non-TB experience. She is not a TB person, so I'm not going to ask a TB specific question. But so being a socially driven company organization that takes beneficial products as soon as possible to the patient. What do you think is Union's role in taking AI solutions from maybe simulating it to actual final delivery?
Union being a social impact organization for one, but also a scientific technical organization, has multiple roles as I see it. At one level, once there is a validated solution which is available, one expects that it is ready to use, but actually it's not so. You rightfully mentioned that there has to be an end-to-end thinking. Most solutions don't come with that end-to-end thinking. Even those that actually do that, once you put it in a live situation, there's much more to it that needs to be added before and after for it to be actually useful and operational. And that's where I see organizations like Union play a role to put that validated solution on the ground as soon as possible, and with everything that is required to make it functional in a live situation. And when I say live situation, with all its constraints, like the human resources that you need to function with, the social conditions in which it will operate, the stigma, the myths, the resistance that it will have to face. So put it in practice there, and then build solutions for that, and then propose it to the program as to how it can be adopted by the program and operationalized most effectively, efficiently. Because another aspect is the cost of any solution. When you look at a solution just in and by itself, you look at the cost at whatever $2 a test or whatever. But when you start calculating these peripheral costs, that's when you will really know what a solution is actually going to cost. And one example is the chest X-ray with AI reading. We worked with the companies when it was introduced in the initial phase to say yes, this is actually workable product on the ground. But now how to use it at scale. So in an urban setting, for active case finding in mass screening, vulnerable population, community-wide screening. What is the kind of human resource that is required? What is the kind of social mobilization that is required for people to actually come and get those X-rays done? And then what is the kind of connecting to back to the treatment plan that is required? Because it's not just about screening and getting the correct results. It's also about how do you then put people on a path to treatment. So that end to end for me, where I sit, is much longer spectrum than where an AI solution, and it's not the innovator's job really. But that's where the role of organizations like Union comes in.
That sort of leads from what Madhu in the previous session mentioned. He mentioned that innovation is not just in AI products, or it's not in lab tests. Innovation is also in processes. It's also in systems. So organizations like Union, it's not like, okay, AI CAD is there, X-ray is there, but then to actually deploy it on ground with the human resources, with all the reliability constraints, with all the social constraints, there needs to be innovations built into stitching all of these things together as an integrated process, as an SOP or whatever is something in a package that can scale across the country. Yes, great. That's the role that Union plays. I would like, if any of the panelists has anything further to add, I'll give the opportunity to you, else I will open it to the floor.
You can speak for the whole day, but I'll try to be short. The reason why I was saying that the disruption is important is while applying AI into any complex problem, there are different placements. Everything need not be disruptive all the time. For example, one product I would suggest is probably just technology. There's hardly any AI into it, but still it is AI because it has used computer vision and it has algorithms. So yes, it is by definition a AI product which is first line, second line LPA developed by Vadhwani AI, validated by ICMR. And there was a lot of argument as to why we really need this. My microbiologist, human error, human touch and the human in loop is must. Yes, agreed. Very important. Human in loop is important. But the same strips and their information was needed for almost a decade for this country, based on which the decisions about the certain mutations and their linkages with the decisions on labeling the individual with certain mutations for resistance or susceptibility against yes or not, and the decisions of the treatment were dependent, and we did not, we waited for almost 8 years. We did not have that data digitized, and we could not analyze it, and we could not take a decision. Now in that came, if with 98-99% of accuracy they developed the product, within months it gets validated in another few months but by ICMR, it may sound like incremental innovation,
but it's also important.
But the value it adds is humongous. But my point was, why we need to do away from identifying the gap is that when the insight is not, this is just like a psychiatric condition. When there is no insight, there is no question of diagnosis, there is no question of health seeking behavior. And unfortunately, I'm not naming the topmost individual, says that, okay, this is our burden and this is our current achievement and this is our gap. It was not appropriate, not correct. So if you don't know what is the total gap, all your interventions, all your design, everything will be targeted towards it. So the missing portion, which is the denominator, if it is not there, then the actions will not be appropriate. And that is the reason I am saying that we need to think differently and apply those principles of artificial intelligence in such a way that we also bring that insight. And the process will actually start from the intention. So if our intention is to only plug the gap which I know, sorry, there will not be enough results, and we'll still end up with the chronic problems augmented further. So that was the only point. But as an innovator, my point was to, someone said I think it was Guy Marx who said that there should be kind of, he used the word, there should be enough agitation for asking for rights and things like that. Similarly, innovators should ask for that access to the data in a legal possible manner, following the country's law. Continuously ask that. And that is the right of the innovators also. And the agencies and the structures are there to support.
So we do not know what we do not know. So great.
One
Yes.
30-second comment. The technology acquaintance from the partner ecosystem in India, including AI, is phenomenal, and they convinced about it. But I haven't seen that kind of acquaintance and acclimatization from the government functionaries, including CTD and further down to the state TV offices. So probably that is something which is we think about like how it is getting adopted at the field, which is fairly, which is fair now. But on the other side, the decision makers are slightly hesitant to embrace this thing.
Great. So that's his again hint is pull from you guys as innovators. Keep crying for access and getting things onto the policy. Great. I'll open up to you. Anybody has any particular questions, specific questions, one word, one sentence questions. One sentence questions. Anybody? Yes. Sorry. I'll come to you next.
Thank you, Manu. So it's really good to have this esteemed panel here. Like 3 AI firms. We have the privilege of using services of 2 AI firms, mostly on imaging, both Qure and I'm Shamim from Clinton Foundation. Both from DeepTek as well as Qure. And what we see now is like clearly there is this massive active case finding drive going in. And clearly we see that there is a need. And also what we see is the space is getting competitive. Like we are talking about future, but for a moment, if we talk about the present, we see that it's pretty challenging in terms of the ecosystem now, in terms of how and where the current player stands vis-a-vis a service which is being offered free of cost. So it is more of a comment in terms of how do the existing players feel about it and how can they go about in the current scheme of things. Thank you.
I can pay. So probably, ICMR has set out like wonderful benchmarking for even ethical guidelines of using AI research. But I think that should apply for everyone. That should not apply only for the private parties. And we have been, and both of us has been complying to all that set by Government of India, CTD and Expert Committee and HTA, DHR, CDSCO and whatnot. But what is missing is that we are not seeing that kind of rigor when it comes to free of cost. Under the premise of free of cost, are we ditching the standards, what we said, which is actually derogatory for the country. So when we position through India AI mission or other thing to the country that we are actually offering a bouquet of AI services, we should also reflect and look back saying what standards I set for my in-house, is my kitchen clean? Is my vegetables clean when I'm making? So when you are doing that, might as well actually do that clearly. We are not threatened by anything done by Government of India. If we can actually fly rockets in month on month, millions of rockets has been there, we can do it. But again, follow the same standards set out by you, which should equally apply for all the parties. Thank you.
I can't stop but comment on this. And also thanks Dr. Shami for bringing this up. Today morning, somebody said, hey, the competition should be fair. It should be open. Why are you worried about the zero cost solution actually? The competition is not open. We are told not to participate in tenders. Tenders ban us from participation. And we are talking about this in a Make in India country, which wants to promote startups who can capture global markets. The amount of investments we have done will run in millions of dollars. And if you support us as a country, we can do magic for India. We are not getting supported.
Great. I hear that sentiment. We'll try and keep it in the discussion that we had. We'll figure out how to convey that message. Ma'am,
Hi, I'm Dr. Neha. I'm infectious disease specialist. So I got very carried away by one word of Dr. Kiran was adaptability. So considering I have two curiosities actually to ask is, one is adaptability in terms of detection, because we are talking about the AI and we still at a piece as a clinician on a data paucity model, because considering TB in a question, we have a lot of heterogeneous population. Sir has mentioned about the subclinical form of TB. We have TB in pregnancy, where the major AI-driven formulations of X-rays and all still have a very much hitch in taking that model shape. So how to go about it? And also we are a country now with extra pulmonary tuberculosis. So we cannot only focus on the pulmonary tuberculosis. And second, my question comes is, again, Kiran sir said about the lot of data set. So how to get about the interpretable AI? Because that is one my major gaps, which I feel that, okay, we have a lot of things to do. How to interpret in terms of our solutions and getting it forward? So these are the two queries I want to ask.
So, we usually see any diagnostics for that matter when it comes to detecting a case or a patient. We usually apply the algorithm directly and it is already fixed in our mind, and we think at the back end about the sensitivity and specificity of that tool or the test, and end there. The issue is there are different tools in different situations with their potential huge range of coverage can give you different results. For example, with all the respects what Dr. Paul sir said in the morning in the panel after his whole deliberation that there should be minimum standards and accuracy, which Shibu also mentioned, that is all fine, but there are different ways of doing things. For example, if you have an opportunity wherein some so-called nonsense information is coming to you and you don't have to do anything, and at the back end you run the AI, which actually Qure has done it in couple of places, and that's why I'm quoting it, that this is possible in different scenarios, and then utilizing that particular information for identifying more individuals without doing anything extra. I'll give you one example of what they did. Is there are chest x-rays happening in this country for n number of reasons, and many a times the intention of the doctor or the clinician is to actually give the clearance because the surgery will be stopped otherwise. So the tendency to declare it as normal and ignoring some small shadows is there, and it is natural. There is nothing wrong in that. But if all those x-rays are subjected to AI, wherein there is no human or natural bias, then it will pick up those who can be tested, and they have found a huge additional yield. I actually estimated this 8 years before, that if we do that thing when we're actually evaluating Qure AI in 2017, that time we estimated that 2 to 3 lakh cases can be additionally identified if we just apply this tool all over across without even talking to anyone. What we just need is minor tweaking of the laws and things like that, and some cost which they can subsidize, of course, when it comes to responsibility to some extent. So here there is no question of algorithm, no question of putting that particular additional test. I say CAD here as a test because the X-ray is already done. You are just taking an opportunity. Similarly, there was a thinking that there is huge information in terms of the voice calls. Voice calls are stored on the servers for some time, not infinite, for some time. That particular information in terms of the mobile connections and the sessions of whether it is SMS, whether it is voice call, on-net call, off-net call, all those are stored for some time, and that is used for so many purposes in this world, with or without our knowledge. Same can be actually used for identifying the cough sounds across the population to identify who can be tested, who needs tested. That's it. It's a simple intervention, just identifying. This was also tried in a very small area in Madagascar by a friend of ours 10 years before. Here, there is no question of accuracy, no question of sensitivity, no question of specificity. Only sensitivity is personal information. So if that is taken care of, there are usually certain opportunities wherein you can take it as a rule in and not rule out utilization of a particular screening or testing, so that you can maximize the detection in a given opportunity, not necessarily in a routine manner.
Just to answer your question on the subpopulation, especially on the pregnancy and all these things, the point of care ultrasound is actually going to be evolving with AI assisted things. So there is a lot of engineering efforts happen making the larger, huge, humongous instruments tinier and tinier. And point of care ultrasound is the best example. So let's imagine that an Asha carries something and then swipe it. It would be a blind swipe and say, hey, there is an abnormality, go and get an X-ray done or go and get a NAT done. So that is something which is in the pipeline. Just want to mention that this country does 100 million X-rays, just X-rays per annum. So just the level of like what Kiran did the projections, and 10 million are happening in the public hospitals, district hospitals. So we have huge opportunity with existing AI itself.
30.
We have time for one more question. I saw somebody raise the hand there. Somebody? Okay. Any other questions? One last question. Anyone? Great. Okay. Thank you. So that's a wonderful discussion. So we had a number of ideas. I'm finding it difficult to summarize it. But in short, there's a lot of opportunities that are coming your way as innovators. Keep on demanding for it, as Dr. Kiran says, and maybe countering to what Aparna said, look for people's opinions, but at the same time, don't look for people's opinions, because doctors may not know what they do not know. So you may know more than what doctors do not know. So look forward for those innovations and disrupt. Thank you.